5, so I'm going to go ahead and get us started. Welcome, everybody. This is the Clinical Consultation Network. We do this every Tuesday at 12:30, so I'm so glad that each of you could join us today. We have got a great guest with us, Jared Adams. He is the Executive Director of Evergreen Life Services and Telehealth Services. And so we're going to get into talking to him in just a moment. In the meantime, I'm going to make a couple of announcements, though, and make sure everybody's aware of our upcoming schedule. Next week is the December the 20th. It's 5 days before Christmas, so I'm going to conduct our clinical consultation network next week. I've got something planned where maybe we'll get everybody involved a little bit. We might, you know how on a television show, periodically they go back and look at some of the things they've done in the past. This will be sort of a retrospective episode that we'll have next week, and a little bit in preparation for Christmas as we're all getting ready for the holiday season. So come and check us out next week on December 20th. We're going to take a break for the following 2 weeks and then return back on January 10th with a presentation that's yet to be determined. Perhaps that will be Mickey following up on his prior presentation regarding team building. So glad that all of you could be here. Jared, so glad you could be here with us today to talk about this unique program that you have of providing telehealth for people with intellectual and developmental disabilities. And so welcome, Jared, to the Clinical Consultation Network.
Thank you. I appreciate you having me today.
So let's start out with you kind of just telling us a little bit about yourself. And don't forget at the conclusion of that to share that fun fact about yourself that probably nobody else knows that much, without going over into the area of too much information.
I have been said that I do that sometimes. I guess I'm just too direct or too honest sometimes.
We all have that tendency from time to time, so no problem.
I
We're
will
very
say,
forgiving. We had somebody, I'll just tell you, Jared, we had somebody report that they were, let's see, I want to make sure I get this right, that she woke up with her husband and a man was standing over her bed with his underwear on. So
wow.
that's how that one I felt maybe went a little bit over the line, but not really.
Yeah.
It was fine. Everybody was very supportive. So don't worry about it too much.
Yeah, I think I'm in the clear then. I think I'm all good. Thanks for having me. I will just a little bit of background on me. I started out working in mental health. I'm an LPC with a mental health service provider distinction. So when I first started out of college, I was doing counseling, more therapeutic, lay on the couch, how does that make you feel kind of thing. And I was also working as a crisis counselor with youth villages at the time. So it was an introduction into social work. It was baptism by fire, when you're doing 12-hour shifts of crisis counseling, responding to those kind of things. I was doing that, and a professor of mine that I had when I was getting my master's degree, I ran into, and this gentleman was working, he was the CEO of Life Bridges at the time in Cleveland, Tennessee. And he kind of talked to me about working with people with intellectual and developmental disabilities. So I had an opportunity to move back to the area, and I went to Chattanooga at Ottawa area and started working for Open Arms. And that's kind of where I began my journey in the IDD world. I started working at Open Arms in Ottawa, just helping with programmatic related stuff. And then I moved to.
And was that an ICF facility, Jared?
Yes.
Yeah. And so that's a great place to cut your teeth on ICF because you learn a lot when you work in an ICF.
You do. And, it's, you wear all the different hats. Like it was wild times in a good way. And I feel like things went really well there. And that same gentleman that had kind of told me about IDD ended up making me an offer I couldn't refuse to come to Life Bridges and run their ICF program there. So I was the director of ICF at Life Bridges for several years. And so worked a lot with them, and then had the opportunity to go to work for Evergreen. And so started out over their division in Knoxville. And then just as I've been here over time, we moved to a model where I became the state executive director. So Evergreen in Tennessee is in 5 different locations across all 3 grand regions. So now I'm the state executive director for Evergreen. So over all operations for Tennessee for Evergreen. And I've been with Evergreen a little over 6 years, almost 7 years now. So it's been great. So as an outsource of that, one of the things that I oversee is the Abundant Healthcare Clinic, and that's the healthcare clinic that we started in Greenville, and just recently opened one in Nashville in our Antioch divisional office. So that's kind of
But these are offices, basically doctors' offices that you've opened in these 2 areas. They're not just doing strictly telehealth. They're
correct.
also doing on-site, in-person services.
Yeah, it's just like a walk-in clinic. We do basic, primary care. Uh, yeah, and so we have we have 2 physical locations now where you can go in and be seen in person by a doc. And that's in Greenville. And then of course the one that we literally just opened in Antioch. So that's kind of an overview of professionally. I will say something interesting that not a lot of people know about me is when I was in college, I worked as a DJ on a modern rock station. So I worked nights on a radio station, and for a short while, I did the morning drive. Which, if you know anything about radio, that's big time.
Oh,
But
yeah.
the great thing about
If
when
you're
I
the
was,
morning guy, that's
yeah,
what you mean, right? Yeah. Okay.
yeah, so it was that was a really fun job. I got to meet a lot of bands and meet artists and things like that. So that's a little known fact that people don't know
Well,
much.
I need to enlist you because you could probably help us a lot with our production here. So that's great. I didn't know you had that history. And so that was when you were in college. I'm often a little bit worried when people start off their sentence with when I was in college, but that was actually a good story from when you were in college. So
Yeah,
that's fantastic. Okay, well, you're cut out really well for today's presentation, I would suggest, if you've had that experience.
I hope so.
All right. Well, so tell us a little bit more. Maybe start, Jared, if you would, just tell us a little bit more about what Evergreen does in general.
Okay. So Evergreen is in 7 states. We've been around for 60 plus years. It was started in Louisiana, and we just kind of migrated our way north and have kind of expanded into 7 states. And like I said before, in Tennessee, we have 5 divisions. We're in Memphis, Nashville, Chattanooga, Knoxville, and then Greenville. And we provide a whole array of services. The only thing we don't provide, I think, is ICF. We do supported living, medical supported living. We are contracted to do Katie Beckett, and enabling technology. And we actually also work a lot with children. So we're working with DCS some as well. So we're doing a little bit of everything in regards to working with people with intellectual and developmental disabilities. And I will say that that's kind of what led us to where we're at with the Abundant Healthcare Clinic is we just felt like, and I won't say where, but some of the areas it was a little more difficult than others. We felt like we were having a hard time getting good coverage for our individuals. Sometimes it was hard just to find a PCP. And then when we did, we felt like the care we were getting was not always what we wanted.
Yeah.
Um, and I will say, I started doing some research on it. I had to write the business plan and everything and submit to our board. And so that included a lot of research. Well, one of the things I started doing is looking at the average time a PCP spends with a patient, just in your typical situation versus serving people with disabilities, specifically people with intellectual disabilities. It was easy to find research on, the average time that a PCP spends with a patient, you know, uh, without that carve out of the intellectual disability. So we kind of did some stuff on our own. And so I had some people we started working with, and we just started timing visits, just going in and just kind of seeing how long they were taking. And I will tell you, and this is how it went down. The average time was 60 seconds.
Wow.
60
I was
seconds.
expecting it to be a little bit more than that.
Yeah, me too. Because the research that I had done, they were saying kind of the industry standard is like 12 to 15 minutes. They kind of know based on their margin how many patients a person has to see in a day. And 15 is kind of the high end, but that's kind of a reference point. I'm thinking it's going to be like, they're probably not going to spend as much time with our folks, but I was not anticipating 60 seconds, which leads to the issue we were having and why we felt like we wanted to uh, have physicians that understood our individuals and that had the patience to work with them. And so when we first began, the first iteration of the clinic, our first nurse practitioner that we had actually had been a nurse practitioner at Green Valley. So very well versed in our population, understood our individuals. So our first group that we had was an individual that had worked at one of our developmental centers, and thankfully she actually went on to kind of do her own thing, start her own clinic, and we still talk with her and can consult with her. Still a good relationship, awesome lady, and also has helped our current nurse practitioner. And our current nurse practitioner worked as a nurse at Green Valley for many years. So had a long, healthy, understands our population very well from all those years of working at Green Valley as a nurse.
And Jared, you're making an emphasis here on people who know the IDD population, which seems to be a relatively important thing. As it relates to any service we're receiving, is the person has some awareness, some sensitivity to people with intellectual and developmental disabilities.
Absolutely. And one of my favorite things to talk about is when we first started the clinic, our first one was in Greenville. We saw our first patient at the very end of 2018, but we didn't officially open until the following year. Kind of had a grand opening mid 2019, right before the pandemic,
Right.
which will get us into the telehealth here in a minute. But so we kind of had our grand opening. We had an individual that had been to his PCP. He was one that was one of those people that we had tested kind of the time. And what we noticed is the staff would take him. Uh, First of all, the staff a lot of times are intimidated to go into the medical visits because they're intimidated by the doctor, afraid they'll say the wrong thing or whatever. So right off the bat, you kind of have that issue. Well, what we noticed is everything was flowing through the nurse. So, Nurse Ratchet would come in and tell the doctor what she thought the diagnosis was, and then he would just stick his head in for a few seconds. Hey, yeah, yeah, good to see you. Good to see you, Bruce. And
Yeah.
Nurse Ratchet says you got a leaky nose, so here's this, and see you next time. So we were starting to run into a lot of that, and we're thinking, man, you should be spending more than the average time with our individuals, not
Right.
less of this time. You have people that are nonverbal, that have a hard time communicating if they can't communicate. So that individual was one of the first ones that the conservator was like, hey, we would love for you guys to take, his case on for your nurse practitioner to be his PCP. So the first visit, and this is not the norm, but the first visit, the nurse practitioner was with them. She was with him almost 40 minutes, talked with the staff, just really interacted with him. Noticed some strange things about his gait. Actually had him get up and walk back and forth. She's like, I noticed something concerning when you came into the room. Will you get up? Anyways, just did some unusual things, right? She's like, I want to send you for these two tests. Turns out he had a tumor on his prostate and it was pretty advanced. So definitely saved his life, definitely extended his life. Uh, and he had been to his PCP 3 times in the past 12 months. No one had run any tests of that nature because there was so little time being spent with him. And like I said, I don't want to go into too much detail because the people get real sensitive when you start talking about, hey, this guy had a pretty significant health issue that was missed for a year. So, and we know how fast things can metabolize and,
Yeah,
anyway.
yeah. Well, the thing about it is, when I go to the doctor, they usually don't spend much time with me, don't want to spend much time with me either. They're sort of like, all right, I need to get you through here. And I've
Yeah.
always got a ton of questions. That's just my nature. Of course, for the work that I do, it's important for me to ask these questions, and they get a little frustrated with that. But ultimately, that's the way that I make sure that I'm getting appropriate health care. But for a lot of the people we serve, they don't do that. They don't necessarily have a lot of questions or ask a lot of questions or do things to slow the process down. And so what your clinic's offering is somebody who's sensitive to that and seeks that information. Uh, Now, I did have a question when you said that you're spending 40 minutes though, because part of the reason these doctors do those brief interactions is because they get paid
Yeah.
uh, by the minute, essentially.
Yeah.
So, how have you overcome that issue?
So, and that's what I was saying. It's definitely not the norm, but what we want is to have that be the availability. Because you're right. In most clinics, I mean, they're running on such a tight schedule that if you had something that was out of the ordinary, it would just wreck the whole day. And what we try to do is when we do our scheduling is build in a little buffer of time for individuals, especially new patients. If it's a new patient that's an individual with an intellectual or developmental disability that we feel like might require extra time, we try to build in a little bit of buffer when we do our scheduling so that there's more time available. Now, I will say, one of the things I've had to learn the hard way because, I'm an LPC, I'm a social worker, and then all of a sudden we had to learn how to manage a healthcare clinic. And it'd be like, hey, Jared, I want you to take these clippers and go give this guy a high and tight fade on his haircut. Be like, I don't know how to do that. That's outside. I don't know what you're talking about. So we had to learn a lot of things. Our patient care has always been excellent, but as far as managing the finances, there's a lot of things we've had to learn as, a small clinic. And one of the things I went and I talked with this group, and it was a healthcare clinic that a group of nuns were running. And the lady said, the mission is in the margin. Jared, if you don't have any margin, you won't be able to provide this mission. So that's what started us seeing the general population as well. Because initially we had
Okay.
this pie in the sky thought of we will only see people with, and we quickly were like, well, we're not going to be able to just do that. Because for this to work, we're going to have to see some other patients and have a little more tighter schedule and be able to see more folks with just common everyday ailments. Uh,
So
so
in
that's
some
what we did.
sense, by seeing the typical population, that's helping you fund the rest of the operation, essentially.
Exactly. Exactly.
Gotcha.
So that's what we had to learn the hard way. And I'll tell you what we have done, which I think is really, really good, is we also offer discounted healthcare to our staff. So in those two divisions where we're at, we're offering this to our staff that might have difficulty finding good healthcare, and even if they do have healthcare, they might be suffering the same issue as our individuals, where because they're on a certain type of insurance, they either the doctors don't take it or they look at you differently. I mean, that's just the reality of it in some of those
Yeah.
offices. So
This just occurred to me though. Does it operate ever like an urgent care where if say a staff member has some sort of an issue where they can't come into work or where they just need immediate care, can they get an appointment through that or would they just rely on their typical urgent care for that?
yes, if it's your common everyday type issues, if somebody had their arm hanging off because they, ran into a farm implement, we'd be like, listen, you need to go on down to
They
the
might as
hospital.
well go on to the ER at that point. Yeah. So
Yeah. But if we have a staff that's saying, wow, I got the sniffles, and we'll be like, well, why don't you just step yourself back to the clinic? We'll take a look at you and we'll run the tests. And, if we need to send you home, we will, so yes, we make that available to our staff for those kind of issues.
seems like that would help some with absenteeism too, if you're able to offer that health care. So that's sounds like a really important part of your organization in that way. Well, that's great. So, how have you now move this, I know you have this vision for telehealth within the clinics that you're operating. How are you moving toward that? So tell us about your progress there and what you have planned.
So when like I said, we had just started when the pandemic hit. So we had never really thought a lot about telehealth, but because of the pandemic, we're like, oh, well, looks like we're going to have to really think this through and, make this more available. And of course, around that time, we were seeing where there were some other, entities coming in, and we saw the importance of having telehealth options and just how valuable that could be for some of the issues that can be serviced through telehealth. So we started doing telehealth visits at that time. So during the pandemic, and we have continued that. And what we have started to do is basically in East, if we have issues with a PCP or finding one, we're doing some basic things with our telehealth for all of East because our Greenville office is in that area. And we are about to start making it available to everyone in the area and do some marketing and some campaigning to say, hey, this is something we can offer too. And I will say, because we're still pretty new and we're still, building our base, that right now we are operating between 8 and 5. And what we are trying to do is look at a couple of new nurse practitioners that can give us some additional time to do the telehealth, because we know that a lot of this occurs after hours. So we are in the process now of building a more robust system where we can have our nurse practitioners and physicians available more after hours. So right now we're just we want to make sure that we have it down to a fine art, of how to make this work. And one of the things that we are noticing personally with our physicians is some of the visits, they're like, what we need to know is, and they will ask some strange questions. And after hearing it, I was like, okay, well, that's how you deal with that barrier. They'll say things like, okay, right now, does it smell like burnt eggs? Or, you know what I mean? Because they're not present with them in the room. There's certain things that, if a physician, and that was our nurse practitioner's original kind of reticence with it, is, there's things that I can see and smell. And
Right.
so what we do is we just build in enough time to ask those questions, or hey, zoom your camera out. Let's see their gait when they walk.
Yeah.
So yeah, we are still trying to figure out the scheduling piece to make it, run smoothly, but it is something that we are now pursuing. Especially now going to start seeing a spike in flu. If we can keep people from having to come into our physical location, we want to do that. So
Yeah, and it's keeping people out of ERs, keeping people out of the doctor's office. There's great value in that, and it's so much more convenient for the person to not have to travel somewhere to do that. In some sense, I feel like telehealth helps people be more independent. It's an area where they're going to have to get a ride from somebody typically to be able to go somewhere else. So this eliminates that need when it's appropriate. Have you had any circumstances where you've used it and you found that it was not adequate to deal with the situation that you were dealing with, and you were going to have to send somebody, have somebody come in or go to the ER for treatment?
yes, just because the majority of the people we've been seeing have been our individuals, with intellectual and developmental disabilities. So either there's not 100% clarity on what they're trying to communicate, or like I said, there's something like, hey, we really need to see this in person, or we need to see that wound, or, we really need to lay eyes on that in person. So if you might need to go in and be seen by somebody in the emergency room. So we have had some of that, but I feel like for the majority of it, the ones that we use telehealth for, it's pretty effective.
So, how is your clinic staffed for this? So you have a nurse practitioner. You mentioned that you had a supervisor for the nurse practitioner. I assume you have a different nurse practitioner at each of the clinics. Um, whom else do you have staffing wise for your clinics?
So we have both clinics. We have registered nurses that are in there. They're thankfully, we've been able to get nurses that have experience in the IDD world. Either they've worked for us in homes in one of our medical supported living homes, or they have past history in the homes, but they also have experience working in a healthcare clinic. And that has been, we have been fortunate enough to find people in both of our locations, nurses that have that experience in both avenues. So they kind of get how the flow of a clinic needs to work, but also understand the individuals that we serve. Uh, so we have nurses in both locations. We have a scheduler in both locations, and then we use a company called Athena for our electronic health record, and they are very well known nationally. There's some small hospitals that use Athena, and they assist us with billing to make sure that we're doing everything correctly. We also partner with them. They have a team that we will go in and we'll be like, hey, do you feel like this warrants a follow-up visit, or what are your thoughts on this? So we can also rely on them too for some of that kind of thing.
So tell me a little bit about the billing for telehealth services, if you don't mind. So if you've gotten credentialed with the MCOs to be able to provide these services, Medicaid services, other services through other commercial insurance companies. And is the billing for telehealth equivalent to doing it in person, or are there any differences there?
There's definitely some differences for us. It wouldn't be on par with what we would get from an in-person visit. Uh, I wouldn't say it's significantly less, but it's considerably less to do a telehealth visit, you know. And so at the end of the day, we have to think this is a benefit for our individual's health overall, and that's why we're good to do it. Uh, but
So
yes, it is
it's not
significantly
necessarily a
less.
moneymaker or,
No,
or maybe even not a break even scenario, but it provides a benefit to your agency to such a degree that it's still worth doing.
yes, yeah, yeah. And if if it's an individual that we have known that we have a pretty good feeling about, you can keep the visit short enough that you could do several in an hour, and it would probably be fine.
Yeah.
Uh, but the benefit of it, you know, far outweighs. But once again, you do have to think about the margins. So
Well, that's right. And you do want to expand this and serve more people. You've got the capacity to be able to do that at this point,
yes,
I assume, from what you're saying.
yeah, and that's what we're hopeful for. Just as the footprint, the base of our clinics grow, we'll be able to grow that telehealth portion and let that kind of take on. I would like to see it kind of take on a life of its own, where we had some dedicated people that are just doing the telehealth after hours, is what I would like to see. So that's what we're in the process of doing.
So tell me a little bit more about that, the after hours telehealth that you're working toward. How do you see that working out? How would that operate?
So it would, you know, it would be just it'd be a scheduling related thing where we would have to have the right nurse practitioner available, and we do have some interested parties. But as you can imagine, because they have that availability, they're going to want to get paid because they're making their time available, and there's no telling how many calls they'll get
Right.
or when. And so for us, that's why we have to build that base margin first, so that then we can provide that service after hours. Now, during normal business hours, we schedule telehealth visits now. You know, so if they're working during normal business hours, that is something that we provide currently.
Okay. And so, do you have any cases? First of all, before I say this, I want to encourage everybody out there who's listening in to ask any questions that they may have. So, or make any comments that you may have, so that we can make sure that all your questions get answered. So, please do put your question in the chat, or if you just want to come off mute and ask a question, we'll allow you to do that as well. It might be good if you raise your hand in electronic sense by there's somewhere up there, there's a device you can press to raise your hand. I don't know exactly where it is myself, but maybe you can find it. In any case, ask questions if you have them. And Jared, kind of going back to a little bit about what we were talking about before, the importance of having people who are very well aware of this population that you're serving and how important that is in being able to do a telehealth service in particular, because as you said before, there are so many things you may not see uh, or know to look for in this population because you're usually reliant on the person to tell you about these things. And often the person with disabilities can't do that. But your staff, I assume, is well trained, well capable of being able to do that.
Yeah, yeah, absolutely. And one of the things we've tried to do, and we're fortunate in this way because we have the healthcare clinics, is when we first started early on, we did some trainings with all of our staff across the state. Number one, to get them more used to being comfortable just speaking to a physician, whether that be telehealth or in person. Because, like I said, during our research, one of the things we noticed and talking with some of the staff is a lot of them were intimidated. Like, I don't want to talk to the doctor. And it's like, yeah, but you're this person's mouthpiece today, because they're nonverbal. You have to assist them in so we've tried to build that comfort level, but that is something that we did have to do is talk with our staff about what might be required, what might be asked in a telehealth visit, having the right environment and the right equipment available to them. So we did make that known to them. So that has helped us with a lot of some of the frequently occurring issues because our staff understand what is going to be required ahead of that visit.
Yeah, it occurs to me though that this really could facilitate a lot of relationship building between your staff and the healthcare provider. I mean, essentially, they're going to know them a lot better than they would even the typical practitioner that you may have in the community.
Yeah, absolutely. That's one of the great things too about some of the people that are close in our where our clinics are actually located is they've been in there and they've been working with an individual. Then they start feeling under the weather. Well, then they feel great. They're like, "This is where we want to go. We know her. Like, I talk to her, once every couple of months, and they have this good relationship with our nurse practitioner already from bringing the individual in there and speaking with them. So yeah, it's been a really cool side effect.
And then extending that, if you end up providing telehealth to that person, you're going to know them so much better because you've seen them in clinic. It's been a pretty seamless relationship up to that point.
Yeah, absolutely. It's exactly how we want it to work, and hopefully will continue to work.
I know that we have I don't mean to call you out. Ralph Kennedy, I know you're on here. I know you have a similar type of service. I just wonder if you have any comment on anything you've heard from Jared here today. You don't have to. I'm just noticing that you're here and wondered if you might have a question or a comment about your own experience, perhaps. Um, but Jared, so what's the future look like here? Where are we headed with telehealth at Evergreen? What do you think the future is with respect to telehealth and having this service widely available?
I would like to see us be able to increase our presence with it. Like I said, just because we know these are the physicians we have understand our population. And I feel like that puts them in a unique position to, especially with something with telehealth, like there's not, you might have somebody that doesn't know to ask certain questions or to look for certain things, whereas someone that's been serving our population for a while, they're going to know. They're going to know to look for those things or ask for those things. So we just want to continue to increase our footprint so that we can provide more telehealth services moving forward. I want to be able to have it in a situation where we can provide it around the clock. um, I know it's going to be a while before we can get there, but what I would like to do is hopefully in the very near future, at least make it available like through midnight, like kind of work our way up to that.
Yeah,
Uh, I think there's a lot of value to telehealth, and we just got to make sure people understand it. I know DIDD as an entity is doing a really good job, letting people know that telehealth's not something evil, that in the right circumstances, it's actually a very good service. And it will save us a lot of issues with common issues that are avoidable. if you're not having to go into an ER, especially.
Yeah, actually, I support telehealth across all clinical services for the right situations. There are certain situations where if you're a therapist or if you're a behavior analyst or, another profession that's billing for services, that it's not appropriate to use telehealth. That you need to be on site with people, be there in person with them. But with each discipline, I think there is an application of telehealth that can be used. I do note Ralph did raise his hand out here, so I'm going to let Ralph come off, and we have also Chris White with her hand up, so we'll get to her next. But Ralph, you want to come on and make any comment from your perspective on this?
Happy to. We started out with a med clinic when we built our office in Smyrna, and we'd already been operating a med clinic and a psych clinic for a number of years in both our Nashville and Murfreesboro offices. The thing that we found with telehealth is it's a good supplement, and it was a godsend during COVID. And we have 16 ICF beds. And so initially, when we started to expand our nursing and then our medical, the good thing about doing ICF is it allowed us to use it as a leverage in order to underwrite some of the costs of the clinic. I have to say, over the years, having the clinic has been a godsend for the folks in our residential services, because we serve a lot in both, supported living, medical, residential, as well as ICF. And these folks require a lot of interventions. And like you said, Jared, they are getting a care they'd never get otherwise. And I've had talks with both the doc and the physician's assistant about expanding. We've been reluctant to really take the plunge that you've taken in just opening up. And I think that the insurance companies would have loved it. They would have loved to just start throwing people at us with or without disabilities. And we've been hesitant to do that because we felt like we were really developing an expertise for this population, and we've limited it to adults. What we've found in our experience is that pediatricians deliver decent primary care to the disabled population. It's when they become adults that it becomes more problematic. And some of the things that you've talked about, we've experienced as well. We grew out of the Parent Guardian Association of Clover Bottom. So the great concern that we had for my daughter and for other folks was that there were a lot of things that were going to be positive in the move of the community, but there were other things that were worrying. And the things that we worried about were trying to find specialty services for this folks. I've felt, and Bruce worked with us for a while as a behavior analyst, that in order to be successful in serving folks, particularly with severe disability, you needed to, what I call as a layman, peel the onion. You had to be able to determine what were the behavioral issues, what were the medical issues, and what were the psychiatric issues. And so we implement a behavioral model. We also have a psychiatric clinic. We're affiliated with Trust Point in Murfreesboro. So, Bruce, thanks for the chance to weigh in. I'm curious as to how all of this talk of telehealth fits in with Station MD.
Yeah, well, so Station MD is another service that's out there. And, that's somebody that I became aware of a couple of years ago. And actually, if you want to go back and look, there have been a couple of presentations that they have done on here. I'm interested in not just acknowledging them, but also acknowledging our Tennessee folks who are doing this, because the idea is I want a patchwork that works for people out there. And so, wherever there's a gap, I want to fill that gap. And you guys are really doing a lot in that regard, I think. I feel so lucky to be in the position that I'm in while you guys are taking the initiative and getting out there and starting these services. Because you're absolutely right. The thing we missed from the institutions was the coordination of the care that people got when they were in institutions. If we're going to make community services work, which is my primary aim in life, is to make community services work for people, we've got to be able to coordinate that care in the community. And that's what you guys are doing. I think that is a strong statement of advocacy for the services and the things that you're developing. I wanted to give Chris White an opportunity. She's got her hand, he or she has her hand raised. And so, Chris, if you want to come off and ask your question.
Sure.
Or,
Hey, Bruce, I'm very much a he.
Okay.
Thank you. But it's Jared, a couple of questions. First, I like the idea. I'm a psychologist who and behavior analyst who's running a large multi-service IDD provider in Massachusetts. And one of the problems we run into that makes getting primary care for our folks more challenging is the occasional disruptive behavior in doctors' offices. And so, telehealth certainly resolves that problem nicely, at least for some things. But my multi-part question is, do you see or do you have any sense of whether or not uh, the telehealth approach is going to increase the siloing between behavioral health and medical treatment or decrease it? I could see the potential for it decreasing, especially in that it might carve out some more time for the clinicians to actually do collateral contacts with people. But the second part is, are you looking to integrate any assistive technologies into the telehealth practice? For example, we have a number of people who wear smartwatches for gathering a variety of medical data that, depending on the physician, neurologists seem to like getting some of that stuff. Not everyone does. Are you doing anything like that?
Those are great questions, Chris. I'm a big tech person myself, and here in Tennessee, we have a provider group called Tenco. I'm actually the chair of the technology committee for that, and that's definitely something that I want to do. To be honest with you, to me, long term, long term, what I see is a place that where you can truly have a holistic approach to the individual within one entity, where we would like to have all therapies available, SLP, PT, OT, where you would have the abundant umbrella and include behavioral health in there, where we could get back to more of a more holistic approach modality to patient care, where you have a group that are all kind of working together that can work on all aspects that an individual might have, whether it be behaviorally, physically, whatever that might be. That is the direction we want to head in. And I think you're 100% correct. Man, technology, there's so much out there right now that can help you. I recently looked at and went to a conference, and they were talking about the information of things. Those
Yeah.
of you that are kind of techie people kind of understand that. And it's basically, just how everything can speak to each other. One of the things they talked about is taking like a provider like Evergreen. You have your EHR, whatever that is, and then you have your medical care, and you can plug all that together, and you can plug in things like track someone's whatever behavioral challenges they might be having. And you compare that and contrast that with they're wearing their monitor and they can see their heart rates going up and down. We can monitor their body weight, their BMs. Well, in the information of things, one of the things that they are working on is a way that you can look at, okay, well, this can be a predictor of an upcoming stroke or a seizure. So by having all that information readily available to you and it all speaking, to one another, there's some really cool things that can be predictive of healthcare issues or, of course, behavioral issues. We all are used to trending behavioral issues that have been in this field for a while. So there's just a whole lot. Yes, we are wanting to get more involved with technology and use more things to help us understand our patients' needs better.
There's so much with technology with regard to communication, with regard to being able to identify potential seizure coming up, as you noted there, Jared. I mean, there are so many things that are coming out, and we've got to try some of these things. You know, one of the greatest tools I have is my Fitbit. I have one that measures my sleep each night, and I can tell you if I'm going to have a good day or not. If I've had an 80 or above sleep score, it's going to be a good day for me. Otherwise, it's probably going to be one of those where I'm really having a hard time. I did not have an 80 last night, so this has not been one of my better days. But I did have 2 nights of 80 in a row, which was great. But nonetheless, technology is such a huge part of where we need to be going. We were just talking to some folks at Progress the other day about potentially doing a study of the use of virtual reality to help people get more desensitized to different sorts of situations that they may be facing, especially going into a doctor's office. And with Chris's remark, it made me wonder a little bit, Jared, if there's an opportunity with this type of clinic to work with people who might be somewhat reticent about healthcare to help them overcome that in more wholesome ways, perhaps, than maybe it's done in the past.
Yeah, absolutely. We, for a short time, and I know everybody talks about the pandemic, it kind of changed everything, but we actually had been kind of investing in some virtual reality programmatic things. Like we were looking at, we had bought some cameras for those kind of things to help our individuals with things that might need a little assistance in getting used to it. And this is a perfect example. For whatever reason, going to a medical office, I know at the Enabling Technology Conference, they looked at, just like public transportation, but also even the dentist, for whatever reason, the dentist, I mean, it just has this effect on some of our individuals. But yes, using technology, virtual reality. And one of the things we could do is with the cameras and the things that we had, that's one of the things we had looked at is going in and recording the actual office, the physician standing in there, and then you could add the layers to it of, as they can tolerate it. But yeah, so much you can use technology for right now.
And even using your facility as a way to help people. I mean, you can't just drop by your doctor's office every day, but you could drop by if you know the people and if they're expecting you, you could drop in just to have a positive interaction with some people, not even get any health care while you're there. Just start to build that as a positive place, a place where you're going to be treated fairly and gently, and so forth. So, that seems to me to be a great advantage of what's being done here. Let's see. I've got a question here from Phil. You want to cover that question, Babs?
Yes. So Phil has asked, I guess he's inspired because he has asked, if I want to start a clinic, what's the first thing I need to do?
Well, I can tell you, you got to be ready for the long game. It is a lot of work, but I think the big thing you want to work with, the big thing to me, the central thing has been finding the right providers, the right physician, and then the right nurse practitioner or PA. Because they have to have the right mindset. And the reality is, we're still a nonprofit. So we know that we're going to be able to say, hey, you probably can make more as a physician other places. They have to buy into the vision of what you're wanting to do. Number one, to spend the time that's going to be necessary. Number two, to understand our population better. So I think if this is something you're serious about, is you have to look to see, can I provide that? Do I have access to a supervising physician that can provide me the kind of care that's going to be necessary? Do I have access to quality providers, nurse practitioners, or PAs and that's something that can be taught, and it might be that they've had good ER experience. We have found that nurses that have worked in the ER, they might not have worked directly with our IDD population, but man, those nurses usually can handle about anything. So You know, to me, that would be the starting place, is that your availability for your actual physicians and nurse practitioners. What is that like? And then you've got to find somebody that can do your credentialing to set up your network. And that can be a long, arduous process, waiting on MCOs to approve you and for them to be approved for your network. And the other folks that are on here can speak to that too, and then deciding, do you want to be the person that's responsible for doing the billing? Because I can tell you, doing healthcare billing is a whole different ballgame than the type of billing you do on IDD services. And I'll say this too, just when we first started billing, and let's say that we billed something for $200 and we got like $88 back, I was like, what sorcery is this? What madness is this? This is what it costs. And they agreed to it. Yeah, we agree that that's probably what this costs, but we're only going to give you 38% or whatever of that cost. So just be prepared for that sticker shock as well.
Yeah. Sticker shock in the opposite direction, as it were. I guess they're sticker shock when they receive your bill. But Jared, do you have any ideas about how to identify these folks? So you're talking about trying to, you've got to hire a physician, you got to hire a nurse practitioner. What methods did you use to identify folks that would be suitable for this type of work that you're doing?
Well, early on with our Greenville clinic, we had been in the community so long that we knew the people very well. And if you know Greenville very well, it's kind of a big little city where everybody kind of knows everybody. So it was easy for us there. Now in Nashville, it's been a bit more challenging, but I'll tell you what we've done is, as we have seen physicians in the community that have done well with our individuals, like maybe they've had to go to a walk-in clinic, I'll be honest with you, we just kind of reached out to some of those people and be like, hey, would you be interested in working with us? So you might already know some people that work with your current individuals that might be open to that, and then you can just, worst case scenario is just put it in your Indeed ad. We want somebody that understands the IDD population and make that one of your answerable questions.
Jared, I appreciate you so much coming on and being our guest today on CCN. This has been a very enlightening episode. I really appreciate you coming and talking to us today.
Yeah, thank you for having me. And if anybody has any questions, you can share my information with them. They can reach out to us. We're glad to work with anybody or help in any way we can.
I think you're going to be approached for consultation on this issue, it seems. So I really appreciate the sharing of information. That is so important. If we're going to build this thing, is for people to share across agencies like this. I think that is so great. And I wholeheartedly want to try to promote this type of service getting built in lots of different places so that we can meet the healthcare needs of people with intellectual and developmental disability. That's our primary aim. Appreciate you so much, Jared. Of course, I appreciate Babs and all of our audience for being here. We do it every Tuesday at 12:30, except we're going to miss a couple of Tuesdays coming up, but we try to be here every week. And so we'll be back next week with a very special episode of the Clinical Consultation Network. So see you next week, everybody.